I need a bigger screen or younger eyes. Magnifying glass would help.
You have a prescription for that? I will take like.
Okay, all right, split the screen so I can see my talking notes.
We can get started, Carter.
Sounds good. Okay. Hello, everyone. I just want to thank everyone for coming out to the second session of What's Up, Doc. My name is Carter LaFontaine, and I'm a project coordinator with the Fraser Northwest Division of Family Practice. My organization is proud to host this community education series with the assistance of some fantastic physicians whose knowledge and expertise are the driving factor behind making these sessions possible, as well as community partner organizations who endorse our various topics of presentation and provide support where they can. So before we begin today's session, I'd like to give gratitude and recognize the traditional lands of the Coquitlam, Coast Salish, Kikite, Musqueam, and Tsleil-Waututh peoples, where we have the opportunity to work, live, and play on. To complete this land acknowledgement, I want to bring the current situation in Canada to the forefront. In May, the bodies of 215 Indigenous children were discovered on the lands of a past residential school in Kamloops, BC, which sparked mass digging of residential school sites across the country. Since then, thousands of more bodies have been located at these sites. This is a tragedy that's really occurred within our lifetime and must be acted upon to support the healing and future welfare of Indigenous peoples in Canada. The Canadian healthcare field has been called upon to address the healing process of this tragedy through education, respectful practice, and working with the courage to stand up for what is right in the fight against systemic racism. So with that, I'd like to take the time to share 21.5 seconds of silence with everyone to remember all of those Indigenous children who were captured from their homes and relocated to these terrible institutions. I'll now be turning off my camera for the next 21.5 seconds, and I will return when my timer goes off. I invite all of you who have your cameras on to do the same. Okay, thank you for sharing the moment of silence with tonight's group. Next is just a little bit of housekeeping. So you'll notice that in the bottom right of your corner, there's going to be a link to the Slido and the code for the session. So the chat's going to be disabled to the audience, and any questions, answers, or comments can be sent via Slido. Feel free to use a phone, computer, or tablet to interact with Slido while the presentation occurs. We will be keeping up with all the questions that you have. If there's any technical difficulties at all, please type a message into the Zoom chat where myself or a fellow team member will do their best to help you navigate. So tonight's agenda, it's going to be a short presentation by Dr. Anna Chodra and Dr. John Yap, followed by a question and answer period where your preliminary questions will be answered, followed by an open Q&A period. And with that, I'm excited to hand things over to Dr. Anna Chodra. Thank you.
Thank you, Carter. My name is Dr. Anna Chodra. I'm a family physician. I'm working in Port Moody. I used to work in Port Moody until November, and now I moved to Coquitlam, but I also live in Port Moody. So I'm a local physician, living in the community and treating patients residing in Tri-Cities area. And I'm going to talk today about a day in the life of a family doctor. So let's start with scope of practice. So family doctors, they can actually do a lot. We're physicians, we're specialists in family medicine. However, we can have areas of interest, and we're physicians who should know a bit of everything about everything. There are physicians who work in their own private offices, like Dr. John Yap and myself. We work in the private offices. We provide something called longitudinal care, which we have. It means that we have established panel of patients that we see, and they're assigned to us. Then there are doctors who work in urgent and primary care clinics that are being established by government. There's also walk-in clinics, and these doctors provide something called incidental care, when the idea is that most of patients should have a family doctor, and then if their family doctor for some reason is not available, they could have this incidental care provided by walk-in clinic or urgent primary care physician. Unfortunately, there's a shortage of doctors, so a lot of our patients end up going to walk-in clinics to get care, and they see those walk-in clinic physicians on an ongoing basis. There are also community health clinics. Kristen, I might ask you for help. I don't think there's one in the Tri-Cities area. I think Douglas College in Coquitlam was working on establishing community health clinics. I think there's one in New West. I don't know if you can help me with that.
Yes, there's Umbrella Co-op has a community health clinic in New Westminster, and that's for new Canadians.
Mm-hmm. Okay. And then family doctors can work also as hospitalists. Hospitalists are family doctors who are hired by health authority, and they provide care in hospitals. So I, as a family doctor working in a clinic, I don't have hospital privileges. So if my patient needs hospital care and it's not too complicated, they're going to be admitted under the hospitalist. So one of my colleagues who provide care in hospital, and once the patient is discharged from hospital, they come back to my care. Then there's also family doctors who are providing primary care obstetrics. We have two major clinics in the Tri-Cities area called CMC, Community Maternity Clinic, and PCOC. It's a primary obstetric. Now I'm my tongue tied, but these are two clinics. One is in Port Moody, CMC, and PCOC is in New West. It's a group of our community doctors who form tour groups. They share the call and deliver babies. They're providing so-called low-risk obstetrical care. Then some of our colleagues also provide palliative care. That's a subspecialty in family medicine, and provide excellent care to our patients in their last months of their life. And some of our colleagues also provide long-term care, like, for example, Dr. John Yap. Aside from his longitudinal family practice, he also sees patients in a long-term care. It's called a Residential Care Initiative. It's also a group of doctors who share that responsibility and call for patients residing in those long-term care. So I do not provide care. I designate my patients to care of excellent doctors like Dr. Yap and some of other my colleagues. There's also some doctors who have other subspecialties. For example, family doctors can do some sport medicine, and they have more interest in more focused medicine. Some family doctors can provide some minor procedures, like we call it little lumps and bumps, removal of skin lesions. It's part of the family medicine within a scope. I think, Kristen, do you have anything to add? Or I think we were just, yeah, okay.
No, I think that's you've captured it. Family doctors do a lot.
Right. Mm-hmm. And then I guess practice styles, for example, like I mentioned about walk-in clinic, so-called incidental care, longitudinal care when we have established panel of patients. So for example, I recently checked, my panel of patients is 2,318 patients. It's a big number, but you can imagine that not every patient comes to me to see me every day. Some patients, for example, I see every few years, for example, healthy women for Pap Smears. I only see some of them only every 3 years. So that's why this panel is much bigger. But on average, I think, depending on the practice, we see about 30 patients a day. Some walk-in clinics, doctors see more. And then hybrid clinic, I think it refers now to virtual care and in-person visits. So with COVID, and also can be both longitudinal care and walk-in clinics. So some doctors have established longitudinal care, but take shifts in a walk-in clinic attached to this particular clinic. But also hybrid clinic can also mean, or hybrid practice might mean that some doctors provide both telemedicine and in-person visits, which most of us right now, we're doing. COVID, this revolution. And over a year ago in January 2020, I would never imagine I would be doing telemedicine. I was laughing at my husband when he said that virtual care is a future. And now I fully integrated, but I see patients both virtually and in person. And that's really complementary. Some patients love it, some patients don't. It's like with everything. Right, so clinic day. So we see everybody who comes through our door, our patients. So we do well baby checkups. We do immunizations. Some doctors do immunizations. Some practices have nurse in practice, and these nurses in practice are great help and support for physicians. They can provide education to new moms about babies, and then also review milestones, and then provide immunizations. On a personal note, I really don't like giving shots. It just breaks my heart to give all these shots and then crying baby. That's just too much for my heart. So I gladly designate it to our nursing practice in the office. We also provide prenatal care and postnatal care. For example, in my practice, I do prenatal care for the first trimester, so for up to 12 weeks, and then I refer patients out to my colleagues who provide prenatal care. Like I mentioned, we do a little lumps and bumps and biopsies. Some doctors feel comfortable and have skills of placing IUDs, doing joint injections. Not every family doctor does it, but we know our colleagues in the community who provide, and we're happy to refer patients to our colleagues to provide that care on a as needed basis. We also have conversations with our patients about their wishes in case something happens to our patients. They cannot speak for themselves, and then who we can talk to. Try to be clear on what patient needs when they end up in hospital or any more advanced care is needed. It's mainly for us to know what you don't want as a patient. Because obviously we want to make sure that patients are provided best care and then they're agreed to that care. We also have consultations about so-called MAID, medical assistance in dying. A lot of our colleagues have these first conversations and support patients through the process and refer patients to Fraser Health in case patients desire to explore that option. We also do a lot of mental health, which we actually see way more patients suffering from mental health problems and crises within the pandemic. It's a significant number of patients a day. We provide not only just medications, but we talk to our patients. The fact that we know our patients, because I'm providing longitudinal care, I know my patients, I can support them, I think, better by knowing their background, knowing their history. So we do provide counseling and can prescribe medications, and we follow our patients, making sure that they're fine, that they get care, but we also can refer patients to available community services like SHARE or PCN. And also we manage complex chronic conditions with patients with diabetes, lung conditions, heart conditions. We do it all, but we also enjoy sometimes seeing simple bladder infection.
I have my hand up because one of the things that's not listed here, and I know Dr. Chodra and I both do this, and we enjoy it immensely, is we also teach. We teach the next generation of doctors who hopefully will join us in this line of work going forward. So that's a major component of what we both do.
Yes, we love it. We basically volunteer our time, and we always appreciate our patients that they allow our residents to see them because they have to learn. And also we're hoping that these doctors will join our community and stay in our community, because we know a lot of our patients are asking, how can we find a doctor? So we're trying to get these new doctors to just stay and then trap them here and keep them here. So they can help us when we take time off, like doing locums for us, and also join our practice and take on new patients that look for someone who can provide longitudinal care. So please support us. So role as a family doctor. So I've been in practice since 2007. And so that's now, it's been 14 years. And I know basically all my patients. I know I went through some happy moments, sad moments, through some difficult diagnosis and miraculous, healings, or, it's just really a privilege to be part of patients' life. We're called family physicians, and I like the part family because sometimes I feel like a member of family. I walk through patients with the birth of their children, death of their loved one, divorces, remarriages, or new marriages. And it's a beautiful moment for us. Sometimes I have this great opportunity just to chat with my patients. I recently had twin sisters coming to my office, and one just said, "Hey, I'm getting married." And well, we did basically push the medical part offside a bit. And I just want to hear about her happiness. So that's part of our part of being a family doctor, but we also manage medical conditions, like we mentioned. We coordinate care. So we're a hub for patients. So I should be this person who refers patients if they need some additional help from specialists. I call it from people smarter than me. If I can't, if my knowledge is not enough to manage and I need help, then I refer out. But this, it also means that the specialist will send me a report. So I know what's going on. If any information is needed anywhere, I'm the person that connects all the dots together. I'm that hub. And yes, we care till the end, right, for patients. And like we are saying, like we are connecting all the resources. We're this resource for patients, knowing our community, knowing resources in the community, and then knowing when and where to send for some counseling that's limited by available to patients. If someone needs social worker, I recently had a patient, for example, who suffered from crisis, could lose his house. That's the person that I will reach out, and they will really call me and make sure that they have all the information, and I will talk to them between the patients. So if I'm getting behind, please don't get upset, because I'm actually managing some crisis situation maybe. We're also in touch with pharmacists. Pharmacists are a great resource for us. We rely on their advice. They sometimes catch those little, side effects or complications or interactions that maybe we missed, and that are great team members. Pharmacists in the community can review patients' medications, and they get back to us, sending the report. But we also have a part of PCN, so Primary Care Network. We have a clinical pharmacist who can visit some patients who are complex and they cannot leave their home easily. We can send that person to the home, and this person will do an amazing job, review all the medications, and send the report back. Usually it's like 3 or 4 page detailed report, and with amazing advice, which I usually follow, because that's, that person knows what they're talking about, and I ask for their help.
Excellent. Thank you for your overview of a day in the life of a family doc. Our next speaker tonight is Dr. John Yap.
And remember to turn on my microphone. Good evening, everyone. Thanks for having me speak. Maybe I'll give you a bit of background like Dr. Chodra did. I am a family doctor. My office is in New Westminster. I've been here for a lot longer than Dr. Chodra. I've been here for 30 years. maybe longer. I lost track. So I may not act my age, which is what some people say. So I've been around for a while. I have been looking after patients in a longitudinal sense, used to do deliveries and go to the hospital and all those things that doctors used to do back in the day. A bit old fashioned, but the new fashion is a little bit different. And Dr. Chodra mentioned that, in that I no longer go to the hospital or deliver babies. So my practice is solely community-based with a group of young physicians, thank goodness. And I do a lot of teaching. So I've been around for a long time and I'm getting old. And getting old is the kind of the theme of this talk. It's about age-related screening. What tests or things we should do over time so that we can all age gracefully. Even if we do everything right, we eventually will all pass, and that's just reality. So the challenge then is to stay as healthy as possible. Aging is inevitable, it's desirable. Illnesses may not be inevitable, and if we do things properly, we can avoid some of these traps, things that might be related to lifestyle choices, dietary things, activities like exercise. If we get vaccinated, that's all the rage right now. And certain health conditions definitely benefit from the right medication. So one of the ways to avoid illnesses is this process of screening. Essentially, it's looking for trouble before the trouble hits. And this isn't random. There's been a scientific approach to this. Some of the things we used to do, we no longer, because we've learned that they aren't helpful. Basically, a good screening test will do more good than harm, where the benefits of doing the tests outweigh the risk. And if you do the tests and act on the results, you should actually stay in good condition for longer than if you didn't do the test. So basically, you'll live longer and also appreciate it. So we don't test for everything. If I had a nickel for every patient asked, can you just check my blood for everything? I'd be able to retire. And it'd also have a lot of anemic, sick patients. So no, we don't test for everything. Screening doesn't always involve blood tests. Sometimes we do an examination. Sometimes we do an X-ray or an ultrasound. There's a bunch of lists of recommended tests, and they're very specific. They're specific for you at a certain age, or maybe for certain genders. Women have specific tests, men have some specific tests. And there's a time where tests are no longer even recommended. There's a couple of sources. One I actually really like is the Canadian resource. It's on the web, and it's called Objective Health. If you want to Google it, you'll actually learn about some of these tests. And I think some physicians would refer to this as well. So as I mentioned, some tests we used to do, they no longer seem to be advisable. Or they've been adapted over time. So a doctor like myself, who started 30 years ago, we have to change what we do. The practice of medicine is always evolving as we learn more and more. So picking the right test, well, that depends on what you tell your doctor. And we've heard this earlier about whether you have incidental care or longitudinal care. The doctor who knows you best is the one who knows you the longest. And they'll learn about you, not just your health problems, but your personal life, your habits, lifestyle, your family, your wishes and wants and goals. Some of the tests are dependent on your age, I mentioned that, and some are based on race. Certain racial backgrounds are more at risk for certain conditions. And of course, gender, and male or female, there are specific tests. Some tests we only do for women or only in children. So I'm going to run through some of this and kind of go through that cradle to grave sort of a motif. Okay. If you really want to know what tests you need, hopefully you can establish connection with a good long-term family doctor, and I think we may address some of that in the Q&A at the end. And just note that these tests that are screening are recommended, but they're not mandatory. You can discuss with your family doctor whether you wish to have it. You can always decline if you disagree. We call this patient-centric care, where we guide you, but we don't force you. Okay. Some tests you may still want, even though they're not recommended, and you can do so but you may be asked to pay privately for that. It turns out that as a family doctor, I'm legally obligated to indicate whether the test is for medical reasons or for personal or so-called private reasons, kind of like having cosmetic surgery. It's not medically needed, but you may still want it. So if I do a test that's not approved and it's billed to the medical plan, that's fraud. And there's actually legislation. There are laws that address this. The law that we were recently reminded about is called the Lab Services Act. Lab Services Act. And if you break that law, you may be subject to significant financial penalty, meaning the doctor is, and possibly even criminal and professional charges. So there's a reason why doctors won't order some tests or ask you that you may have to pay for it. Okay, so getting past that, there's definitely some tests that we do. And I don't know if the audience is a wide range of age. I'm just going to run through maybe from beginning and then into the older group what some of these tests are. And it's not complete. It's just a sampling, and I'll give you an inkling as to why. At birth, babies are tested for a variety of metabolic disorders, basically anything that might be inherited as a defect that could cause them issues. So all infants go through something called a heel prick test. If you've had a recent newborn, you might notice that they have a Band-Aid on one of their foot before they leave. And we test for lots of things that we can now treat and address and prevent future problems, including thyroid troubles and adrenal disorder. There's something called the BC Early Hearing Program, and children get hearing tested sometimes before they leave the hospital, but soon thereafter for sure. That's run by public health. And it's a little bit more scientific and complex than what we do in our office, because apparently they actually check brain activity during the hearing test. As we get a little bit older, there are regular visits. Dr. Chodra talked about newborn vaccinations, which she doesn't like to do. I kind of share that sentiment. Fortunately, we also have a nurse. But when the babies come to our office for their shots, we also examine them and we review. So some of the screening we do is during the exam. We screen for vision and developmental milestones, and we check. So if it looks like I'm playing peekaboo or playing with a flashlight, I'm actually screening for such things as vision and lazy eye and cataracts and stuff like that. So it's part of the exam. Other tests that we might do are based on maybe the parents' racial background, like blood disorders, thalassemia, and sickle cell. We may not do them on every child, but we pick and choose the ones who best benefit from that. So now moving away from childhood to adulthood, there are definitely a lot more screening tests. And when we ask for additional information from our patients to take that full-on history, we will ask about lifestyle, about their smoking. We screen for such things as unhealthy drinking habits. If your doctor doesn't ask, you might volunteer that information. Smoking is the scourge of healthcare system. We definitely should be asking for that. A screening test we should do for everyone is check their blood pressure. It is truly a silent killer. All right, it's not a blood test, it's a mechanical test. You can do it yourself if you can find a blood pressure machine at the mall again. And in some age groups, under age 30, if you are sexually active, we actually recommend screening tests for sexually transmitted infection. And that applies to both men and women. There's a recommendation to screen for hepatitis C. It's a little bit different in the States versus Canada. But even if there's no risk, a single check is recommended. So if the doctor asks out of the blue, have you ever had a hepatitis C test? And that's the reason. He's following screening guidelines. That also applies for HIV tests too. And it's not any longer just for high-risk patients. Obviously, we did target those going back 20 and 30 years. But right now, it's recommended for otherwise healthy adults to have a screen at least once. We currently screen all women for this when they're pregnant. And the reason is there's something we can do about it. And we can help mother and baby be healthier if we know in advance. Diabetes screening is recommended for anybody over age 40. In Canada, we kind of do something called risk stratification. We kind of look at you overall and estimate if your risk is low, which we may not do a screening for, or if it's medium or high, then we definitely would promote that. So some screening tests, I said, are gender specific. Dr. Chodra mentioned Pap smears. All women are recommended to have Pap smears if they're over 25 and have been sexually active. Breast cancer screening has met some controversy recently, but you may start at age 40. You probably should at least by age 50. And then depending on circumstances, we may recommend even more frequent tests than every 2 years. For men, we recommend checking their cholesterol by the time they hit 40. As long as they're otherwise healthy, we still would recommend screening. So, you know, if you're 20 and you want to know what your cholesterol is, we could check, but you may have to pay for that privately, unless you give us a good reason, like maybe a family history that puts you at higher risk. Women can get their cholesterol checked too, and screening usually begins a little bit later. They recommend at age 50, and we don't or should not check every year. In the low risk patient, it's every 5 years or thereabouts. So asking every year actually doesn't make sense. You may be asked to pay for that one. Now, if you actually have heart trouble or stroke trouble, then you're not in the screening category anymore. So indeed, the doctor may take a completely different tactic if you have certain medical conditions. One that had been circulating for a while is for the older man over age 65. They recommend getting an ultrasound once in a lifetime to check for an aneurysm in your abdomen. That recommendation is maybe more strong if you've been a smoker or have high blood pressure. So I don't think a physician would say no if you ask for that. Maybe we should be asking more of our older men for that. There are some tests that have met with controversy, especially in the last few years. The one that always comes to mind for me is checking for prostate cancer. I used to recommend PSA, blood test screening for all men after a certain age, and also to get, you know, that finger test that all men dread. Well, that recommendation isn't so strong anymore. As a matter of fact, there may be recommendation against doing that. That's what exists in the Canadian Task Force for screening. They recommend against doing that. There are mixed messages from other groups like the American Task Force, as well as the Canadian Urological Association. But if that's something that worries you, you need to discuss this with your family doctor, and he'll present to you the pros and cons of doing the test. I said earlier, a test is good if you intend to act on it, and it does help you live longer, and you appreciate that. And some of these tests are no longer recommended because they don't check all those boxes anymore. But again, individual needs vary, and definitely have a talk about it. One test that's not controversial.
Sorry, you know what? I'm just going to jump in. I'm sorry, John, that I'm interrupting, but what you're doing, and I love when you're saying we used to do this or you used to do this and then we're doing this now. What it is called evidence-based medicine. So we are not deciding that, oh, you know what, suddenly men over 50 do not need a prostate exam with a, a physical exam with prostate. Someone else done a study on population and decided, you know what, it actually doesn't make a difference based on the studies. So why men over 65 should have an aneurysm? Because that population is higher risk. So someone, again, compounded all this information from population and done studies and then provided it with us with evidence called evidence-based medicine, and all physicians should practice that. We're all trying to do that.
That's so true. We're not making this up. I'm not that smart. I read the recommendations and I try and follow them, and recognize that next year they may come out with a new recommendation. They're always constantly looking at what the evidence shows. One thing that has no controversy is colon cancer screening. All adults above age 50 should undergo this test. In British Columbia, This is done by the so-called FIT test, also known as the poop test. And sometimes that leads to colonoscopy, sometimes it doesn't. But it's definitely recommended, and it's kind of all automatic now. The lab has figured out how to do this as a separate program. We do the screening when it matters. There's a time in our lives when it doesn't really matter so much anymore. So there's a stop date for many of these. We stop colon screening at age 74. We may stop breast cancer screening at age 80, perhaps. And Pap Smears screening, we stop at age 69. And that's based on the science. And again, we're not making this up. But some people actually do live longer than we expect. And as an individual, we can negotiate, when it's appropriate. Some people have so many other diseases happening that screening makes no sense any longer. And that's the least of the problem worrying about breast cancer if somebody, for example, has advanced dementia. And again, the doctor who knows you best will know what's appropriate for you. So I guess the key message here is find that doctor, and I know that's not always easy, and stick with the doctor who knows you best. And only and when absolutely necessary, take advantage of the incidental care options. Ideally, if we had a magic wand to wave, we'd have everybody assigned to a family doctor in a patient medical home, and all these things would be done so seamlessly. We're not there yet. We have to train a few more doctors, right? And that's the end of my talk. So I'm happy to field questions after this.
Great, thanks, Dr. Yap. Next, I'm going to pass it on to Chris and Ash, who's going to be reading out the Slido questions.
Perfect. And I'm just going to switch my screen. There we go. So, Dr. Yap and Dr. Chodra, I will read out the questions, and then if you want to, either one of you wants to answer or both, just jump in, and we'll start with this first one. This is always a hot topic. We see it in the news. I think it's how I spend most of my days and many of my sleepless nights is considering this. So the question is, why do we have such a shortage of family doctors? And maybe, John, yeah, or Dr. Yap, yes.
I have some of the answers, only because I've been around so long. There was a time where there were too many doctors. At least that's what the government thought. This goes back to perhaps the 1980s. When I graduated, it wasn't guaranteed that I'd be able to practice medicine. There was the idea that a couple of economists were promoting to the minister at the time, Minister of Health, that the cost of healthcare was directly proportional to the number of doctors that we had. So more doctors, more costs, less doctors, less costs. We could save money if we didn't train more doctors. And that's basically, they accept it as the truth. And now we have a problem because our costs are not related to the number of doctors, but the demand for healthcare, which got ever increased by aging population, increasing technology, higher drug costs, and on and on. People are living longer because we're doing a great job, and not because we've trained too many doctors. Our medical school has doubled or tripled in size over the last 30 years.
So we have the postgrad UBC program is the largest family medicine program in Canada. We have 300 graduates across the BC graduating from family medicine program. And I'll let you finish, but I can also comment on some of the observations we have, why these new doctors don't want to settle into longitudinal care.
Dr. Chodra, I believe just, was it 2010 or 20, 2012, there was only 200, maybe it's even more recent, only 200 seats were available in the medical school.
That's true. My medical school class, there's only one campus, one medical school. There was 128 students, and that remains the same for the next 10 years. And only about 15 years ago, they've doubled the size. The 300 family physicians are not all graduates from UBC. We are begging, borrowing, and stealing from other provinces and even other countries to, make up for the shortage. And we're still behind the 8 ball because, believe it or not, doctors do get old. They do want to retire, and they get sick too. So, we have to replace them, and it's not so easy.
A lot of young doctors, when they graduate, they don't want to settle immediately into longitudinal care. What they're trying to do is explore different practices. So for example, they will do so-called locums. So for example, when I have my full-time practice, I want to go on holidays from time to time. But I need to have someone who can look after my patients, see my patients when I need to see a doctor, look after results. And that's so-called locum. So those new doctors are doing that. But also being a teacher and showing them what's involved in family practice, they get sometimes scared because it's a lot of work. And then we see, let's say 30 patients, sometimes 35, or some doctors even more sometimes, because it's just such a demand. And we doctors have really hard time saying no. So we accept more patients than we should have, because it's heartbreaking stories, so we want to help. And then after seeing those 30 patients or 35 patients, we have to finish paperwork, we have to finish notes, we have to make referrals. Then we have to review reports, which is about probably a day. For the established practice is about 70 documents a day. I have to review consults, lab results, investigations. And when these new doctors are seeing this, they get scared. So we have to groom them slowly. It's not so scary. But it's a process, and it usually takes about 5 years for those new grads. They've done even studies themselves during the residency program. It takes them about 5 years to decide if they want to establish longitudinal care. But some of them, they end up being hospitalists. Some of them choose another subspecialty. They can go into emergency medicine, palliative care, sport medicine, and they never really settle into longitudinal care. We also have a group of international doctors called IMGs, and these doctors actually do have to settle into practice. They have to do something called the return of service. So we have every year we have few positions in our community that those doctors settle into practice, but we have, let's say, I think this year we're going to have 3, and then it's way below needs of our community.
And before we start the session, Dr. Chodra was also saying, physicians are paid by the government, but we are small business owners, and we have to pay the bills. And as everybody knows, the price of everything has gone through the roof in the last few years, and that's no different for physicians. So everything that we have in our office, we have to pay for out of the fees that we get. We are basically small business owners and subject to the same pressures as any self-employed business people.
That's a really great point, Dr. Yap. One of our challenges, I'm not even going to call it an opportunity, I'm going to call it a challenge, is the cost of office real estate in, especially in Tri-Cities and in New West. There is not enough that is available, but in Tri-Cities, with all of the new development that is beautiful, looks beautiful, bringing all these people, the cost of medical office space is actually the highest. It's one of the highest in BC, if not the highest, and especially in Port Moody, and even higher than downtown Vancouver proper. So it goes to show we are working, and I know our municipal partners are working with us to identify opportunities, and we'll continue to do that. I'll move on to the next question. And the next question is, it is a bit of a medical question. So because I know that both Dr. Yap and Dr. Chodra will remind me that it is very difficult without having a full history to make any type of diagnosis. But Dr. Chodra or Dr. Yap, could you maybe just answer if somebody had blastocystis, and I probably said that wrong, hominis parasite in their gut, who would be the best, where would be the best place to get care?
Well, I guess the person hopefully has a family doctor, and then please contact your family doctor. Even though a lot of family doctors do virtual care, we do see patients in practice in person, but you can sometimes schedule a phone call. If you cannot, if you don't have a family doctor or your doctor is not available, then you can see a walk-in clinic physician for that. And then you can also ask that walk-in clinic physician, please send this information about it from this note to my family doctor, so you can give the name. So your family doctor can have all the information, and they can call you. Hey, I saw a note. You went to see a walk-in clinic. How can I help you? A lot of times that's what I do. I see patient went to urgent care clinic or walk-in clinic, and I'll give them a call just to touch base.
Yeah, I think that's a good advice. And I know it's easier said than done, but having a doctor to call your own to share your concerns with would be really helpful. If this test was indeed done at a walk-in clinic, your doctor may not have that information, and it can be very, very, time consuming and frustrating to have to, get that information. But if you can ensure that, if you attend a incidental care clinic and have a test done, that it gets back to your regular doctor if you have one, and then they can do something about it.
Thank you both. This next one, I'm maybe going to just share. So again, why don't we have extra family doctors in Vancouver, but I'm going to say Fraser Northwest. I would love to have enough, let alone having any extra. But what I'm going to do is, let me see if I could just, I'm going to just share my screen. I just want to share where one could look if they didn't have a family doctor. And Carter, I will get you to send this out after, just to everybody that's attended. But we have in, and I think is it showing the map of Coquitlam? Okay, good. I've got a couple screens going here. So, so this is a website called Pathways, PATHWAYS, medicalcare.ca. And so when I land on this page, Pathways medicalcare.ca, if you have a family doctor, you can look up your family doctor here. So let's look up Dr. Yap and see. I'm going to guess that there's one, and I'm guessing that's you, Dr. Yap, in New Westminster. And so his information for his patients will all be there. And he's got some information if his patients want to get in touch with him, book an appointment online, that sort of thing. So let's go, if somebody did not have a family doctor. So find a family doctor. Let's put in Coquitlam. What you will find is there is a map, and there are different clinics on here. Some of them might be walk-in clinics, and some might be clinics that are taking on new patients. And so these are physicians or nurse practitioners that have put their clinic and listed their clinic on here, similar to what used to happen on the BC College of Physicians and Surgeons website. We try to make sure to remind them, if they're not taking patients, to remember to take their name down. Sometimes they forget or have gotten busy. But we do definitely try to keep that. And then up here, there is a Find a Family Doctor. And if you're looking to get on the list to get a longitudinal family doctor or primary care provider, we do have some nurse practitioners that have joined the community as well, and you can get registered there. Right now, the wait is approximately, as of last month, was 230 days on average wait. However, this is the best time of year. This is the time of year that we get the most excited for. All of the graduates have just finished their residency program. And so this is when they are looking to start their new practice. So we were to have 2 physicians join our community. One is welcoming a beautiful baby shortly, and so she will be starting a little bit later, so we'll probably see her later. I suspect next summer. Hopefully that's the one thing that we've come to know. A lot of the family doctors, because they're so worried about their patients, don't end up taking very long to take the time off to have their own babies. Typically, they're back within 4 to 6 months, which is just not fair, but that's okay. We're going to continue to find ways to help them to take that time off. So hopefully we'll send out some of those links for you so that if you have any of those questions, you'll be able to use those after. So let me move on. Did I go back to the questions page?
Mm-hmm.
Okay, excellent. Okay, so here's one. Why doesn't my doctor refer me to the specialists when I ask? I thought they make referral incentives. So this is something, Dr. Chodra.
We don't make money by making referrals. There's no incentive for referring patients. College is very also strict. College of Family Doctors, College of Physicians and Surgeons of BC. We don't get any payment if we refer you to a physio or chiropractor or massage therapist. We don't sell any products directly. Actually, a lot of my colleagues have a policy that if you need a referral, you need to see their doctor, talk to their doctor, because we just don't get paid for this extra paperwork. So if we make a referral, we don't get paid. So sometimes, and then it's always with the longitudinal care, it's just a prescription refill. But then there's so many other questions I can ask. I can review, are you up to date with all the screening? Or when was the last time you had this or that done? But also there's another part of why my doctor doesn't refer me to, especially when I ask. That's the role of family doctor. We always want to explore why you need to see a certain specialist, because sometimes we can ask some of the questions. With our knowledge and our experience, we can answer a lot of questions. If we can't, then we'll definitely ask for help. But a lot of things can be solved at our level of a family physician.
That's such a great point, Dr. Chodra. Oh. Go
yeah,
for
I
it, Dr.
completely
Yap.
agree. We know a lot about everything, perhaps not in the same depth as a specialist would, but we could save you a lot of weight and grief and angst by helping you with the problem if we can. So an automatic referral shouldn't be expected. We are kind of bound by the same rules as the lab. We have to make referrals wisely, where they would be helpful. and not randomly or without good justification. Some are necessary because there's ongoing follow-up required. A lot of eye specialists worry about, checks every 6 months for glaucoma, and those referrals are inevitable. But I take Dr. Chodra's point that, every time we make a referral, it is extra work, paperwork, the stuff that we enjoy, not. When the office asks you to come in to discuss it further, it's simply, as a courtesy, so that when we do this for you, that we actually can pay the bills and then do the referral, not for free, but because we want to make the referral when it's appropriate.
Excellent. I know when I had my kids, or when they were babies, I had friends that were in the States, and they would talk about they had a pediatrician. And so I remember thinking, oh, do I need a pediatrician? But here in Canada, it is such a very different model. And I think in a lot of ways it does. And I've heard that our family doctors here are have far more experience in everything. So that's wonderful.
I'm Polish, and in Poland it's also known. And when I was a kid, I remember my parents would take me to pediatrician. That was just a custom and just normal, right? We didn't have family doctors. So I remember my visits to pediatrician, but here in Canada, well baby check when the baby's growing well and there's no concerns, there's really no need to see a pediatrician, for example.
That's a great one. Thank you. The next one, I don't have a family doctor. Can I go to a walk-in clinic and get referred for a blood test? So that one, and I can answer that, but yes, you would be able to. The other alternative is the urgent and primary care clinics, and we have one in Tri-Cities, and you'll find it on that Pathways Director as well, similar to a walk-in clinic, but you could go there and they will be able to follow up with you.
I would add, as part of my talk, I said for blood tests, the doctor will have to decide whether the test is appropriate for you. So it does help if you give as much information to assist that doctor who may have met you for the first time as to what the need is for that blood test. If it's determined that the blood test isn't a medical need, then you could still have the test, but you'd have to pay for that privately.
Yeah, that's a great point. The other one, Dr. Yap, that you mentioned in your talk was about the screening. And what I was just thinking is that there are clinics. So some people that don't have a family doctor worry about not being able to get their age-related cancer screening. But if you go to the BC Cancer website, all of the clinics and the ways to self-refer, and in our community, if for your follow-up, you could have your results sent to the urgent and primary care clinic, and they will be able to follow up with you. Excellent. Okay. The next one says about 2 years ago, I was told that they have arthritis in their feet. They have muscles, their muscles in their legs cramp up a lot. And the question is around seeing, is this a time to see a specialist now? This person is worried about neuropathy. Skin is prickly all over, and would these be related? I know that without knowing the full medical history, there would be a lot. I can see both of you have like those bubbles with all these questions. You need, there's a lot of things that would need to go into this. And my guess is that your recommendation would be to talk to your family doctor or your nurse practitioner.
Yes, the other thing is if you have a family doctor or you go to a walk-in clinic, tell the doctor what you worry about, because then I can tell, you know what, yes, I agree, this might be a problem, this might be related, and I will make an appropriate referral. Or I might say, you know what, I don't think that's related, or I don't think that's the case, and I will give you my reasons why I don't think that's the case. So it's important to talk. And then you might say to your doctor that, well, I have arthritis for 2 years, and then now I have these symptoms. Do you think it could be neuropathy? Can I see a specialist? And then your doctor can obtain more history and guide you through this process.
That's really helpful, Anna, Dr. Chodra. One of the questions that, or one of the things that I've heard as well is it good to bring a list? I know some people I know, and sometimes I think I should, just at least write down the question that I wanted to ask the doctor when I'm going in.
I like lists, but I will not be able to go through a shopping list of 10 issues. So I like lists because I can see on the patient, I always pick and it's like, hey, what's next? And what we can do is, because our time is limited, you can think if I'm seeing patients for 7 hours a day, like with a 1 hour lunch break, I have 30 patients a day. I can have maybe 10, 12 minutes per patient. I'm not able to go through some of the issues. And what we're doing is in trying to have a balance to answer your questions, answer your most worries, but sometimes your worry that worries you the most might not be the one that's actually important from a medical perspective. And I will tell you why. So we have a bit of negotiation, but also family practice is a specialty where we can see patients on multiple times. The other thing is telehealth. It's a silver lining. You don't have to leave your home. You don't have to drive to my office and wait in my office. All you have to do is sometimes wait a bit at home for my phone call because I might be getting behind. But it's we can then easier schedule those multiple visits if we have to divide that. But all the issues are important. And I think we'll be having next question about one issue per visit. That's the next one. But I like lists. I don't like to address all the issues on the list in one go because I also want to do a thorough job and answer and take the history and manage the issue in depth. But it makes our job easier. I don't know, Dr. Yap, if you agree.
I completely agree. I mean, I think we all want to look for that one answer that explains our 10 complaints, but sometimes there isn't one, and sometimes we can't sort it all out in one visit. We may have to pick and choose which battles to fight now and which ones to fight later, and do it over a period of time so that we can actually, spend the time wisely and prioritize what's most needed, and decide together what we can cover later on. First and foremost is we have to ensure safety of the patient. Doesn't come to harm. So we may ignore certain things over others because we recognize what's more worrisome from our standpoint.
When I teach residents, I usually give an example of someone coming with the fungal infection of the toenail, and they really want me to fix it because it's summer and they want to wear flip-flops, and it's very important. And then at the end of the visit, they say, oh, by the way, I have a chest pain, and here I am. And then the chest pain, I really have to make sure the person is not about to have a heart attack. So, please, I like the list up front. So I can say that, what, I think fungus will not kill you, but a heart attack might. So we have to be really prioritizing here and make sure the patient safety, like Dr. Yaps mentioned.
That's excellent. And is there, just on that, I'll just add, is there a limit to how many times a patient can see you in a year or a month or a day or a week?
Yes, we cannot bill for so if you go to a walk-in clinic and then you call your doctor because you love your family doctor, you want to make sure that you got the right diagnosis, we will not be able to bill for that, but you can see me every day for 360 days a year, every day, although nobody will do that. But yes, you can see me as many times as you want, as often as you can, if you need to.
There may be rules about going from one clinic to another, that Teleplan might take issue with, so-called multi-doctoring. It happens very rarely, and it'd be very unusual circumstances, and definitely they would try and figure out why and how we can actually do better if you're seeing that many doctors.
I think I want to add one more thing to a lot of problems during the one visit. Bear in mind, there was a question about walk-in clinic, that a lot of walk-in clinic doctors have this one issue per visit. Ideally, we would like to see one issue per visit because it also comes from the just financial reasons. We're not getting paid for more issues. So if you have 5 issues and we address them, we will not be compensated more for 5 issues. We're just compensated for 1 visit. I wish I could spend 1 hour with patients, but then I would not be able to pay my overhead if that was the case.
Well, and we'd have a lot more people without a family doctor to call their own. So that's a big part of it.
Yeah, I mean, what'll happen is, if we try and spend an extra 20 minutes with that one patient with a long list, then the poor waiting room just gets filled up and the next patient is half hour behind and just gets worse and worse. So if you're ever wondering why the doctor's always late, not on time, maybe because, other patients are bringing their shopping lists.
So this next one, Dr. Chodra answered it a bit. My neighbor told me that you can only ask a doctor one thing per visit, but my doctor never told me that. Is it just some doctors at walk-in clinics that do that?
So we try to do one issue per visit because, like, imagine in 10 minutes that we usually have for patients, we have to take a history, we have to find out what's wrong, we have to examine you, and also then make recommendations. But so we try to do 1 issue per visit. However, I'll be honest with you, unless it's like more than 3, I usually try to go through the list. Sometimes we can plan for the future visits, we can order quick test and then discuss it later, or we can review, but it's always a discussion, is that, maybe we can discuss it next time. And then just your family doctor who's providing you longitudinal care, they're just really nice to you because they like, and we are really have hard time saying no to patients.
Thank you. So this next one, I really need a family doctor in New Westminster. When can you help with that? Q&As and surveys from this website, but never help with the purpose for which many of us join this group. When can you guide us in finding a family doctor? And I completely agree. I think it's very challenging, and what we've been able to do in the meantime is find short-term solutions that we know are not what is needed, but we continue to do the best work possible to recruit family doctors. So one of the best ways to recruit family doctors, and like both Dr. Chodra and Dr. Yap suggested, we have a lot of really great teaching physicians. And so if you do have a family physician, or you're at the hospital and they come in and they ask, is it okay if the student or the resident comes in to join? I know it may take a few extra minutes of your time, but the more physicians that we're able to train, whether it's a specialist, family doctor, nurse practitioner, anybody that we can help train in this community, the chances of them staying in the community are just that much greater. And then if you know anybody who has real estate, commercial real estate, and wants to provide good lease rates, we're always welcome to connect providers to you. Dr. Chodra.
I just want to add one more thing. Great thing about seeing learners is because I always give them extra time. and they really want to impress me as well. So they take this detailed history, they do a very detailed physical exam, which I'm just sometimes getting shortcuts, and they actually do provide a great care. And then it's also like having consultation within my practice. You have another set of eyes looking at your issues, and also remember, all the residents, all the students, they have to review your situation, your clinical presentation with their attending. So even though I might not physically lay my eyes on you or touch you and examine you, my resident will always review this, and then we'll come up with a plan that's together. But they're always, and also they're very excited seeing patients, and they're very excited diagnosing patients with conditions. So they're very helpful.
Excellent. Thank you. The next one, how can I find a doctor in Vancouver that has a US medical license in addition to a Canadian license? Based on the physicians that I know that have, especially right now with COVID, or since COVID happened, going back and forth is not something that we see a lot of. And so many doctors don't carry their licenses if they're not practicing in multiple countries, because the cost of being insured and their licensing requirements for multiple jurisdictions is quite significant. So that I would not know
I think
any
maybe
way to do
college
that.
website, right? The College of Physicians and Surgeons of BC might have that information. But also, it would be really interesting to have more information where this question is coming from, because in Canada, you have to see a physician who is licensed in Canada. Maybe for some patients, it's important for the insurance purposes to be seen by someone who has recognized license in the US, but you cannot. But yeah, I think the college will have that. But like you mentioned, Kristen, it is very expensive. So some physicians might carry that license for a few years, but then if they don't practice in the US, they will just give up that license because it's several $1,000s a year.
Yeah, probably the college would have that information, but there's not enough in this question to really help more than just suggest that you explore through the college.
Okay. What if I have a family doctor and they don't prescribe what I want? I'll let you answer in your own way, but I'll also maybe add, what happens if you have more questions and you're not feeling like you're not feeling like you're being heard? What if it was one of your patients, and I know both of you, what would you suggest that your patients do?
Tell me.
I'm guessing that you would just say, tell me, talk to me.
No, but you know what? Sometimes there's this focus from like patient's perspective, and patients have agenda, but doctors have agendas as well. And we always try to meet, but sometimes I'm just so wrapped up about something that it's really caught my attention. I really want to make sure that this is addressed because I really think it can have serious consequences later on. And I'm just so focused, and I have this tunnel vision that I might not really see your point of view. And I had some patients telling me, you know what, last time I had this, not less than satisfactory, visit with you. And I actually enjoy it. As much as stressful and I'm sad, it's never my intention. So I can almost guarantee you, if you have a family doctor that's provides longitudinal care, we want to meet your expectations. But also, I would recommend you listen to your doctor, because if I don't want you to take certain medication, there might be a reason. So please, the same goes both ways. If I don't hear you, maybe you don't hear me either, right? So please, it's a dialogue. And then sometimes it's a negotiation. That's why it's family doctor. And then, sometimes I want patients to take certain medication. They really are resistant. And it takes me several visits. And then sometimes it applies to the doctor. doctors are hesitant to prescribe certain medications, and you work on your doctor to, to get what you want by presenting your case. I don't know if that answers the question.
I
The
like
question
that.
it's vague, but it actually brings up lots of potential issues. Hopefully you've given your doctor enough information, they understand what your fear is, what your ideas are, what you expect, but then they have to use their training, their experience, their knowledge to decide if that's indeed the best choice for you, the best option, or potentially a dangerous option. A good doctor should explain the reasons for that, explain, why this might be a bad idea. Or, sometimes we promote certain medications and tell you why it's a good idea, but again, you may decline to take it, and that's all right. I think you should have that choice. But ultimately, the doctor is responsible for what they do, and we have to do what's right for you, that's safe for you. And if we seem or feel that it's not, then we won't be doing it. We won't be prescribing somebody who's known to have an allergy to penicillin any penicillin. It's just not safe.
I like that because I think all doctors, and Dr. Chodra, it just reminds me, or when you were sharing that, it's amazing. Doctors are human too. Just like the rest of us, I'm guessing that you might have good days and bad days and hard days and easy days. But it's hard. I think we see you all as superhumans, but you're not. You're humans, which I love and adore. So, oh, this is a good one because this is an interesting. I hear this all the time. Why can't I see my doctor in person anymore? And I know in our community, all of our doctors are seeing their patients both in person as well as virtually, either through telephone or through some of the different digital platforms, depending on their preference and their patients' preferences. But do you want to maybe speak to that?
I'll start by saying that I was like Dr. Chodra, in January and February of last year, virtual care was the last thing on my mind. I thought this is ridiculous, that no. But obviously when the fear of COVID hit, we weren't sure that it was safe to go out. We weren't sure it was safe to see anyone live. So we had to pivot very quickly and find our way. And I have to say, even a year and a half later, we're still trying to figure this out, what works best. What I can say with certainty is virtual care is not going away. Seeing your physician live is not guaranteed, but it should be available when necessary. And I think the college actually says as much. If you're only offering virtual care and nothing more, that style or practice may not be allowed as we look into this further. And I agree with what Kristen has said, that pretty much every clinic now has found a way to integrate virtual care with live or in-office care in the safest manner possible for both physician, their staff, as well as for the patient.
And starting September, we will be adjusting our schedules as well, because we're still operating in the COVID pandemic. And the September is the time when we're going to review guidelines and then see how we can adapt. Right now, we're trying not to have as many patients in the waiting room, just to avoid contacts and keep that social distance. But hopefully, starting September, we will be able to see more patients in the office. But every colleague that I know who works in a clinic, they do both. So if you have a doctor who doesn't see patients in person, they're probably one of those private platforms. They're advertised, and these are not really community physicians seeing. So I also would advise you to call your doctor's office. before you make that decision to go to emergency, maybe your doctor might not be the same day in the office, but they might, if it's something urgent, they might ask their colleague, hey, Dr. So-and-so, could you please see this patient because they really need to be seen. So that avoids you stress of going to emergency. And also emergencies are really overloaded right now. And then so please give a call and just make sure that you have accurate information.
Yeah. If you notice that, you're still asked to wear a mask and you're not allowed in the office directly, it's because we're still a healthcare facility that has to be extra cautious. We can't allow patients, to be crowded into a room. We have to scrub every room down after every patient because, again, we can't let our guard down yet. We're a long ways from that. So things are getting closer to normal, but it's going to be far from normal for a while to come.
But as our survey, when we reached out to the general public in our community, as much as people would like to see their doctors in person, there's still a desire to have virtual options. And so we're excited. I think most of our clinics will have a blend of both. And but it's going to take some of us, like me, will have to go in when my doctor says you need to come in, and I can't do it by phone, and I'll go in, I promise. The next question, I have osteoporosis. The scans show low density in hips. I'm wondering if that means I have low density in bones throughout my body or just in that location. And I'm guessing that this might be one of those questions that you would have to see the full scan and have all the information. But is this a good discussion that would be that would be a great topic to go in and have that discussion with your physician, especially if it's that you're worried about it.
Yes, but also just to and ask a question about the test, because osteoporosis is measured in various points of the body, so it might be different. But then once you were diagnosed with osteoporosis, it means osteoporosis, we take the lowest measurement. But have a discussion, maybe have a look at the report. What does it say? And then ask your doctor to explain what it means, because we measure spine, lower back, we measure hip, we measure and then femur bone. So there are different areas where we measure.
Thank you. Next question. When should I go to the emergency department or my family doctor? When I need blood work or x-rays? ?
No, so emergency is for emergencies. We actually had discussion with our emergency colleagues, who quite a few of them are family doctors, and they chose to also self-specialize in emergency medicine. When you go to emergency department, you get admitted. You get admitted to the emergency room, and it's not just a quick blood work or quick x-ray. It's a whole process. So when you are in a situation where, well, maybe it's not urgent, that you're not having this crushing chest pain, or you think, maybe you sprained the ankle, but you can still walk, this can wait. Rather than waiting and going to emergency, call your doctor and see if you can talk to your doctor or see the doctor or their colleague, and they make them decide if you need to go to emergency. Because a lot of things, there's only a few situations when we would really send patients to emergency. There's a lot of things we can do from our offices by phone or in person. So please, I'm begging on the behalf of my colleagues that I talk to, don't use emergency room as a walk-in clinic. They are really burnt out and they're really stressed. And this stress really transfers onto the community, to the patients, and to us colleagues as well.
Excellent, thank you. So we've got 4 questions left and we've got 6 minutes. So what are the symptoms of prostate problems?
Maybe I'll address that. Basically, this is a male problem that just changes how your peeing or voiding pattern is. So there's something that's different that's bothering you. That's something to take up with your family doctor. The doctor will probably ask you a dozen or so questions to determine how severe it is and maybe recommend some treatment. So again, you'll have to take that up with a family doctor, and hopefully you can find one through the help that we've posted.
I recently had shoulder surgery and had to purchase a special sling and also an ice machine, approximately $600 plus. What happens to those people that are unable to afford to buy these types of things?
There's some equipment that we can write a prescription and the Red Cross will rent to patients, so we can write a prescription. Sometimes, and usually when you have a surgery, then it's up to orthopedic surgeon to prescribe these. So patients should share that, well, I don't think I can afford it, and they should be able to find an alternative. It's just, sometimes it's just easier to have an ice machine, but well, maybe you can just put an ice pack on the shoulder, right? That's much cheaper, but that's something that definitely addressed with the surgeon, but also talk to your doctor, because sometimes we can make that referral to Red Cross and write a prescription.
It's true. This is new technology, as I hinted at in my talk. But we haven't always had ice machines, and we may do. So they'll have to just go old school and find a way around that. And I'm sure they can.
I'm sure that you've had to do that a few times, Dr. Yap, in your biking accidents. Dr. Yap may have been practicing for 30 years, but still likes to do reckless downhill biking. The next one, how does your advanced care plan get to the emergency department at the hospital? Dr. Yap.
I think Fraser Northwest is a pioneer in this area. We've had this in the works for, I'm going to say, at least 8 years. Right now, if you have that discussion with your family doctor, there's a special form they can complete. It's kind of like a prescription. It's complex. I won't get into those details, but we were the first health authority to have a repository of advanced care plans in the form of something called the MOST form. So we were able to fax that to medical records, and they would put it in the hospital system, so that if you were sick enough to end up in the hospital and you weren't able to speak for yourself and there was no one else to answer for you, then we would have in advance, you know, what your wishes were at a time that you had a discussion with your family doctor. Now, so that's wonderful. That means, as Dr. Chodra said, you know, you get to say what you don't want, so they don't do things that you wouldn't have requested or desired. You make your wishes fully known. Having said that, if you're able to answer for yourself, those plans go out the window. You're able to say at that moment, when we explain to you what the problem is, what we can and cannot do, whether or not you wish to proceed. So if you're competent and capable of answering, you're always the decision maker. It's when you're too sick or unwell, incapable of answering, having that guidance well beforehand is helpful. Or having somebody you trust, your substitute decision maker, know what your wishes are, then they can speak for you on your behalf. That's also very helpful.
I always also do one thing when I have a patient and I have a discussion and we fill out the form, MOST form. One thing, like a Dr. Yap mentioned, I fax it to a central fax number, but I also give a copy to the patient. You know, just have it. And there's also something called green sleeve, where you can put all the information onto that green sleeve, like a plastic wrap, and then you could put it on a fridge that has a magnet. And then, for example, if you call ambulance, they will know that that's the green sleeve. There's the information about your list of medications, MOST form, and then the other advanced care planning decisions that you made.
Yeah, that's a great point, Dr. Chodra. I had that last week with my own father, because the ambulance, even if the advanced care plan is in the emergency department, the ambulance drivers don't have access to that. So it is good to have a copy at home. And last question, are some vaccines mandatory for babies and young children? can you share a basic schedule and timing of vaccines for babies and children, and also what the vaccine is for? I can say that on the schedule, we do have it on Pathways, the community Pathways, and Carter will be sending out a link to that as well to the attendees, and we'll share that. But do you two want to talk about whether or not the vaccines are mandatory?
That indeed is an interesting choice of words. Anything that we offer, there are very few things that are mandatory that are not like legislated by law. Like you have to wear a seatbelt if you drive a car. That's, I guess, mandatory. But we certainly promote, healthy living, and part of healthy living is prevention. And vaccines are the greatest thing since sliced bread for prevention. So we definitely recommend all the available universal vaccines for children. Some of the vaccines for adults are not fully funded, so you may have to pay privately for them. I'm a total proponent, advocate for getting vaccinated whenever and wherever possible.
But then there's a list. You can also go to Immunize BC, and some provinces might have a difference in vaccination schedule. So if you go onto Immunize BC and Google basically childhood vaccination schedule, there will be like a PDF 1-page or 2-page document with all the vaccination. And just a comment about the mandatory. If you come from communist country, like I am from Poland, I was born in those days. My parents would go to jail if they didn't get vaccinated. Thanks God, we're done with the communism and people have a choice. However, I still recommend vaccination and prevention. But yeah.
And maybe we'll do a topic like that in the upcoming months. Carter, did you want to close this evening, or?
Yeah, absolutely. Just quickly here. I just wanted to say thank you to both Dr. Chodra and Dr. Yap for the wonderful presentation. And a thank you to everyone for attending tonight's session. I'll be sending out an email to everyone who provided their addresses with a quick survey link and an overview of some of the resources chatted about tonight, along with the division resource on how to connect to a family physician. We'd really appreciate if you could take a few moments of your time to complete the survey. It just allows us to understand what was successful and what could be worked on, along with any suggestions you may have for future sessions. If you have any other questions about tonight's presentation, feel free to send me an email. I've provided it in the chat below. And other than that, thanks everyone. I hope that you all have a good night.
Enjoy the sun.